Okay, good morning, or good morning, afternoon, evening, or middle of the night for all of our participants and guests. My name is Eli Diamond, and I'm the chair of the Rare Disorders Steering Committee of the Histiocytes Society. I'm very pleased to welcome you and our speakers and panelists to this webinar session brought to you by our committee. We all know the great work that has been done by the Histiocytes Society over the years. Just some very quick housekeeping items. Please put comments in the chat, and please put questions for the speakers in the Q&A box. We'll have time for questions in between. Dr. Gaurav Goyal is going to give a brief introduction before we have the three speakers. Gaurav, take it away.
Thank you, Eli. Hello, everyone. Welcome to the Rare Histiocytosis webinar. My name is Gaurav. I lead the Histiocytosis program at UAB and will be providing some introduction on the talks today, which are very exciting. Next slide. These are my disclosures. So as we all know, the histiocytic disorders have been classified into these 5 groups based on clinical as well as molecular phenotypes. And in adults, for the most part, the 3 common histiocytoses that are seen are LCH, Erdheim-Chester disease, and Rosai-Dorfman disease. That's sporadic, and these are what we will be discussing about today in general. Next. Over the last decade or so, we have learned a lot about histiocytosis, especially ECD and LCH. The first disease where we found BRAF V600E mutation was Erdheim-Chester disease in 2010 in half of the cases. Subsequently, in 2012, it was found in Langerhans cell histiocytosis. And thereafter, we found a large number of mutations in the MAP kinase pathway and beyond, including kinase fusions. And a lot of work that was done to discover these alterations led to the classification of both these disorders, LCH and ECD, as cancers. Initially, they were thought of as inflammatory disorders. Next slide. But what about Rosai-Dorfman disease? It's unclear at this time whether to call it cancer or not. Officially, it is not considered a malignancy. However, we know that RDD can affect any organ system of the body as well. It is a little diverse and unique disease in the sense because it has these various associations. It could be immune associated, it could be neoplasia associated, familial, or IgG4 related. Interestingly, in the last few years, we have found MAPK pathway mutations other than BRAF V600E in approximately 35 to 40% of the patients. The first mutation that was found in 2016 was KRAS mutation. Next slide. There is not much known about systemic treatment options in RDD just because of the variable practices depending on who the patient saw. The standard of care treatment was prednisone or other steroids with variable response rates. Chemotherapy as well as rituximab has been used as well, along with some other immunosuppressive agents. But it is not yet clear what should be our first go-to therapy in Rosai-Dorfman disease. Next slide. Interestingly, there are some reports of efficacy of immunomodulators like thalidomide and lenalidomide in Rosai-Dorfman disease, as shown by this case series of 7 cases showing CRs in cutaneous Rosai-Dorfman disease with thalidomide. As we all know, if we have used thalidomide in other malignancies, there are some challenges associated with this drug, such as neuropathy. So it is naturally of interest to look at whether lenalidomide could be used in this disease, as it does not have the associated side effect. Next slide. So today we will be hearing our first presentation from Dr. Sao, who will be presenting on lenalidomide and dexamethasone for Rosai-Dorfman disease. Next slide. The discovery of MAP kinase mutations has enabled using targeted therapies. Dr. Diamond was leading this arm of the VE basket study in histiocytosis. All patients were mostly ECD or LCH. RDD does not have BRAF V600E mutation usually, but this study showed robust responses leading to vemurafenib approval by the FDA in 2017. Next slide. For patients who don't have these mutations, MEK inhibitors have been utilized. Dr. Diamond again led this landmark trial with mostly ECD patients, 2 RDD, 2 mixed histiocytosis, and 2 LCH, showing a very high response rate in these patients. However, we don't know if cobimetinib is effective in a larger cohort of Rosai-Dorfman disease, given there were only 2 patients in this report. Next slide. So we'll be hearing from Dr. Abekun today about efficacy of cobimetinib in Rosai-Dorfman disease and what they found. Next slide. Further, in other histiocytosis, ECD and LCH, we have some signal that shows that if we stop BRAF inhibitors early, you can have progression in over 75% cases with a median time to relapse of 6 months. But it is unknown if the same applies to MEK inhibitors and whether there are any predictors which will help us choose carefully the patients where we can successfully take a break from targeted therapy and to help, because that's a challenge in management of these cases, as we may be aware from our practice. Next. So today we will be hearing about outcomes following interruption of targeted therapy in patients with ECD and other histiocytosis from Dr. Diamond. Next slide. That's all I have. I will give it to Dr. Sao, and we are very excited to hear today's presentations.
Thank you, Grau. I will share my slide. Okay. First of all, I would like to thank the Dr. Diamond and Dr. Grau. It is a great honor to be here to share our data with you guys. And today my topic is lenalidomide and dexamethasone for Rosai-Dorfman disease. I'm Xinxin Cao from Peking Union Medical College Hospital. I will start with a case. This is a 20-year-old young female presented to our hospital with an 11-month history of painless, non-pruritative subcutaneous nodules in her lower limbs. The subcutaneous nodules gradually extended to her upper limbs and her trunk, with diameter of 0.5 to 1.5 centimeter. And then she gradually developed nasal obstruction for 7 months. Her past medical history was nothing special, and so we did a biopsy. A biopsy of the nasal mass was performed, and the specimen showed large atypical histocyte positive for CD68, CD100 and 63, and S100, and negative for CD1 alpha with few IgG4 positive plasma cell infiltrating. And pyropolis was readily apparent. And this is her picture. We can see the specimen positive for S100, CD68, and negative for CD1 alpha. We also did the head MRI. It demonstrated soft tissues masses in the nasal cavity and the right maxillary sinus. So the Rosai-Dorfman disease was diagnosed. As we all know, Rosai-Dorfman disease can be everywhere, and also it can be related to immune disease or neoplasm. Also, some patients had family history, so we did the workup. The patient didn't have something special for family histories. Her CBC, her liver function, and renal function were all normal. The anti-ANA, ENA, ANCA, and IgG4 were all negative. And we did a PET scan to reveal where is the disease. And the PET CT scan revealed the bilateral nasal mass, ethmoid sinus mass, right maxillary sinus mass, mediastinal mass, and multiple subcutaneous nodules with a maximum SUV of 20. We also did the NGS of the specimen, and the NGS showed MAP2K1 at a VF of 2.9% and the BRAF Y472C at a VF of 4.3% and also an ARAF D113N at a VF of 7.5%. And now, so this is the question: how should we treat a patient like this? As a patient has multiple mutations in MAPK pathway, we thought about cobimetinib, which is a MEK inhibitor. However, the drug is not available until now in China. So we thought about the immunomodulator drugs. Why we thought about the immunomodulator drugs? Since we had previously reported 3 refractory nasal RDD cases who had been treated with thalidomide. And after the treatment, the patient had a long-term remission. So this give us some idea, maybe immunomodulator drugs can work in RDD. Also, we also use thalidomide, cyclophosphamide, and dexamethasone to treat relapsed and refractory adult LCH patient. So I will talk about a little bit about our TCD trial. This is a prospective phase 2 study for adult LCH patient who relapse or refractory to first-line chemotherapy. Thalidomide 100 mg every night, cyclophosphamide 300 mg per meter square on day 1, day 8, and day 15. Dexamethasone 40 mg on day 1, 8, 15, and 22. Also, aspirin was prescribed to prevent thrombosis event at the same time. All drugs were taken orally. Totally, we enrolled 32 patients. All these patients had median 1 length of chemotherapy before the enrollment. And this figure showed the response dynamics and the survival profile. We can see the green one, the green bar means the time on TCD regimen, and the orange one means the time on thalidomide alone. And also, this one shows the follow-up of the TCD withdrawal. We can see the overall response rate was 87%, including 56% of patients were classified as CR, and 31% of patients were classified as PR. While the median overall survival and the median infect-free survival were not reached yet. While the estimated 1-year and 2-year EFS of the whole cohort was 89% and 64% respectively. We can see the patient with risk organ involvement had similar EFS as a patient compared to patient without risk organ involvement. So why do this patient has such a high overall response rate? We tried to figure this out, so we did the immunohistochemo staining for the cerebrum. We all know the cerebrum is the immunomodulator drug tapped to effect. So we did the immunohistochemo staining of cerebrum on the tissue specimen of 17 LCH patients, and almost all disease tissue highly expressed cerebrum. So this may be the reason why IMiDs can work. So from this result, we used the lenalidomide and the dexamethasone for our patient. Lenalidomide 25 mg from day 1 to day 21, and dexamethasone 40 mg on day 1, day 8, day 15, and 22 for 6 cycles. And the patient's subcutaneous nodules disappeared, and her nasal cavity obstruction gradually resolved. After 6 cycles of lenalidomide and dexamethasone, we did the head MRI again, and the repeated MRI showed that the initial soft tissue mass of the nasal cavity and the maxilla sinus was almost completely disappeared. We also did repeated the PET CT scan. The PET-CT revealed a dramatic improvement in the multiple lesions with only a single high optic locus in front of the nasal sphincter remaining, and all the other things goes away. So, based on this promising result, we registered a prospective phase 2 study to explore the efficacy and safety of lenalidomide and dexamethasone in Relapse-free disease. The regimen including lenalidomide 25 milligram from day 1 to day 21, and dexamethasone 40 milligram day 1, 8, 15, and 12, and 22 for 12 cycles orally. After the 12 cycles of LD, will take lenalidomide 25 milligram from day 1 to 21 for another 12 cycles for maintenance therapy. Aspirin was prescribed to prevent thrombosis events. And the primary endpoint of this trial was event-free survival. From June 2021 to March 2022, totally 15 patients were enrolled in our study, including 11 newly diagnosed RDD patients and 4 relapsed and refractory RDD patients. The median age at diagnosis was 42 years old, ranging from 20 to 67 years old. In the 4 refractory or relapsed or refractory RDD patients, they take 3 patients take the steroid, and 1 patient takes cladribine before the enrollment. And this is the organ involvement at their enrollment. Totally 15 patients, we can see more than half patients had a bone involvement, and about 40% of patients had skin and lymph node involvement, followed by sinus, central nervous system, laryngeal and orbis, and muscle and vessels. So this is the baseline organ involvement. And since we only did 9 months treatment, so only 12 patients can take the response. And in newly diagnosed RDD patients, after 6 cycles of lenalidomide and dexamethasone, 2 patients had a complete remission, while 7 patients had a partial remission. And in the 4 relapsed or refractory RDD patients, 3 patients got partial remission after 6 cycles of lenalidomide and dexamethasone. Well, this is really a premature data, but from this point, we think lenalidomide and dexamethasone is a promising regimen for Relapse-free disease. Thank you for your attention.
Thank you, Dr. Sao. That was very interesting presentation. We are open for questions. Please post questions in the Q&A section. I will maybe get us started with a question, and please others can chime in. It's interesting that it seems like the regimen you used is sort of borrowed from the myeloma world, where we use dexamethasone 1, 8, 15, 22 with len. I was wondering, what are your thoughts about what is the efficacy of dexamethasone in addition to lenalidomide versus just using lenalidomide as a single agent, especially given those 3 cases that you had who did not respond to steroids, and it seems like those were the 3 who had a partial response. That was something that stood out to me.
Thank you. This is a very great question. So actually, I don't know, because if we don't do the RCT trial, we actually don't know if the plus dexamethasone make better than only lenalidomide alone. But for our patient, for that single female patient, we did add dexamethasone because the patient have very heavy symptoms because the nasal obstruction. So we thought maybe we use dexamethasone can help her symptom resolved. And also the prednisone or steroid in rosiglitazone seems to be the first-line treatment. So that is the reason we add dexamethasone with lenalidomide. Yeah, thank you.
And we have a question from Dr. Go. I think it's similar to what you just answered of activity of IMiD alone. And then there is a question: in children, RDD quite often disappears with nothing or only steroids. Is that seen in adults in your experience? Does RDD go away on its own, or with just steroids, a little bit of steroids?
Yeah, actually, the same answer. I don't know. Maybe we'll try to do our RCT, but in this rare disease, it is very hard to do a RCT trial to compare just the IMiD alone or IMiD with steroid. But some patient, I don't know, maybe just like our patient, is a little bit too heavy to just use IMiD, in my opinion, because IMiD may have a long-term shot to resolve the symptoms.
Then we have another question: did you see any responses in the central nervous system, given you had some patients with CNS disease on the study?
Yes, actually, 2 patients. Oh no, I'm sorry. In this prospective study, no patient. I'm sorry. About 20% of patients have CNS involvement in this trial, and most of the patient had the symptoms resolved, since we all know IMiD can pass the BBB, and also dexamethasone also can pass the BBB. So that's the reason we didn't exclude the CNS patients.
Okay, we have maybe time for one more question if any of the panelists has one. Otherwise, I can ask something.
So, Dr. Sao, what's the duration of treatment for this Rosai-Dorfman study?
Oh, in our study, we designed totally 2 years, 1 year for lenalidomide and dexamethasone, and 1 year for lenalidomide alone. Because of in our first patients, after 12 months RD treatment, lenalidomide and dexamethasone treatment, she relapsed soon. Maybe after 8 months after we stopped the treatment, so we add another 12 months lenalidomide to hope the EFS can do better. Yeah,
I think the duration of response will be really one of the critical questions for this, because my general disappointment with chemotherapy for especially these sort of bad extranodal Rosai-Dorfman cases is not that they can't get a response, but that they don't last. So I think that it'll be very interesting to see whether the responses are as lasting as they were for your patients with LCH.
Yeah.
Osama, you have a question?
Yes, thank you. This was interesting. Were there any side effects from lenalidomide encountered?
I didn't show in this trial, since the data is very premature. But in this kind of young patients, the side effect is okay. Basically, the hematological, the leukocytosis or thrombocytosis, maybe grade 1 to 2, not no grade 3 thrombocytosis. Yeah, sorry.
Well, I think this is all the time we have for questions. Congratulations, Dr. Sao. We look forward to your results, and thank you for staying up at midnight for presenting here.
Thank you.
Dr. Ebekun is going to go next.
Hello, everyone. Can you hear me?
Yes.
And see the PowerPoint presentation?
Yes.
Okay, thank you. Hi, I'm Jitma Bekon, and I'm a hematologist at Mayo Clinic. I will be presenting this today's presentation on behalf of the Mayo Clinic, University of Alabama, Birmingham Histiocytic Working Group. So today the presentation is to show the effectiveness of cobimetinib in Rosai-Dorfman disease, especially those who carry KRAS and MEK mutations, mutated disease. I have no conflicts of interest to disclose. As we all know, that Rosai-Dorfman disease is a rare histiocytic disorder with 100 new cases per year reported in the United States. And about 40% of patients would have MAP kinase pathway alterations in Rosai-Dorfman disease. And importantly, there are not much reports which could document the efficacy or effectiveness of cobimetinib, which is a MEK inhibitor in Rosai-Dorfman disease, especially with respect to MAP kinase pathway alterations. To date, there are 8 reported cases, and of those 8 reported cases, the first 3 patients had underwent genomic sequencing to assess the MAP kinase pathway alterations, and the other patients did not. So the patient number 2 and patient number 3 are from the seminal clinical trial led by Dr. Diamond, where the sequencing was done and no pathway alterations were assessed, and one had a stable disease and the other one has a partial response. Patient number 1 had KRAS mutation and had a partial response. But apart from those, there are no cohort studies for us to assess the efficacy or effectiveness of cobimetinib in Rosai-Dorfman disease. Therefore, we aim to assess the effectiveness of cobimetinib in large series of patients with Rosai-Dorfman disease in an outside of clinical trial setting, and also to delineate the impact of cobimetinib in Rosai-Dorfman disease, especially with respect to MAP kinase pathway alterations. So this is the methods we screen patients with Rosai-Dorfman disease diagnosis who have been seen at Mayo Clinic and University of Alabama, Birmingham from 2013 to 2021. The response was assessed centrally by our expert radiologist, Dr. Jason Young, by using the published criteria, the PET response criteria, which is used by the seminal clinical trial put forward by Dr. Diamond, and also the CNS response was assessed by the MRI response criteria, which is already published and used. Treatment was done with cobimetinib with 20 to 60 milligrams as at the discretion of treating physician, given 21 days in a 28-day cycle. MAP kinase pathway alterations were assessed by using public platforms such as Tempus, next generation sequencing platform. Gain of function alterations in RAS, RAF, MEK and ERK mutations, ERK alterations were classified as MAP kinase pathway alterations. 89 patients were screened, and of those 89 patients, 16 were treated with cobimetinib. That means 18% of patient cohort. And of those 16, cobimetinib was used as frontline in 7 patients. Median age of these 16 patients were 57 years at the time of treatment initiation, and majority were females. Median follow-up for the entire cohort of these 16 patients was 19 months, and the median duration of cobimetinib treatment was 5.5 months. The overall response rate was 62% for the entire cohort, which is 16 patients. And of those, that means 10 patients responded, 5 with a complete response and 5 with partial response. Cobimetinib was used in 7 patients in the frontline setting, and complete responses were seen in 3. And it was used in the relapse setting in 9 patients, and 5 responded, and complete responses were seen in 2. Importantly, there was not much difference when cobimetinib used in frontline or the relapse setting in these patients, and the response were the same. This is the pie chart of the response. 62% was the overall response rate. Complete response and partial response was 31% each, and 38% of patients did not respond. So the MAP kinase pathway alterations were assessed in all patients, all the 16 patients, and we detected somatic alterations in the KRAS and MEK genes. There were no other alterations that we detected in the MAP kinase pathway genes. So we classified our cohort into 2 buckets. One is KRAS MEK altered, and the other bucket was the KRAS MEK wild type. Importantly, the overall response rate was significant in KRAS MEK altered patients compared to wild type patients, which is 87.5 compared to 37.5, and it is statistically significant. This is the swimmer's plot of all the 16 patients. You can see the upper half is the patients who had MAP kinase or KRAS or MEK alterations, and the bottom half who did not. And there were 2 alterations, PIK3CA and SMARCA4. And These are the respective mutations. I would like to highlight two things in this swimmer's plot. Number one, patients who carried the MEK and KRAS mutations actually had a durable and deep responses compared to patients who did not. Number two, such as you can see from the green, as complete responders only could be seen with the KRAS and MEK mutations. Number two is that despite the mutations, adverse effects were common and majority were dose limiting or dose changing, which I will explain in the future slides. So those are the two things that I would like to highlight in this swimmer's plot. Progression-free survival is also significant, as you can see from the red line, which is the KRAS MEK altered. After 19 months of follow-up, none had an event. While in wild type cohort, majority had events, so that the median progression-free survival of the patients who did not have KRAS and MEK alterations was 12 months, compared to not reached in the wild type, in the altered patients, and the p-value was 0.008. Interestingly, out of the 16 patients, 12 patients were started at cobimetinib at lower dose. The FDA approved dose for a dose was 60 milligrams, but they were started at 20 and 40 at the discretion of the treating physicians. Important to notice that patients, those who started at 20 or 40, they also had significant responders. So 7 patients started at 20, 5 patients started 40, and of those 4 patients responded, and 4 patients responded each with achieving complete response as well. Patients who started at 60 milligrams, 4 patients, 2 responded, and all those 2 had complete response. Overall response, in summary, was actually not different in patients who had started at lower dose compared to full dose at 60 milligrams, 67% versus 50%. Important to notice that there is a numeric reduction of grade 2 to grade 3 adverse effects in those patients who started at lower dose compared to higher dose, 67% versus 100% respectively. This is a graphical representation of a patient who had complete response. All these patients had extranodal Rose-Hydorfman disease, and you can see that complete response achieved by PET scan with cobimetinib. Adverse effects were common. So most importantly, the highest most frequent adverse effect was rashes, which was seen in about 70% of patients, diarrhea, decreased ejection fraction, nausea, musculoskeletal pain, anemia, acute kidney injury, and retinopathy were the other adverse effects. Important to notice that although the adverse effects were common, rash was well managed with doxycycline, minocycline, as well as steroids. The decreased ejection fraction actually returned back to normal in these patients after treatment hold or decreased dosing. And so as the retinopathy, after decreasing the dose, the retinopathy was actually improved from grade 2 to grade 1. Dose-limiting toxicities, mandating dose reduction or dose discontinuation was seen in 9 patients, 56% of the total cohort, and cobimetinib was discontinued in 9 patients due to adverse effects in 5 and due to disease progression in 4 patients. Limitations in our study, of course, it's a retrospective study, so it is biased with its own own inherent limitations. Quality of life measurements we could not assess due to the nature of the study, and also relatively small sample size, but this is the largest cohort of patients that is reported so far who has Rose-Hydorfman disease and treated with cobimetinib. And also because of the retrospective nature, we may have underestimated the adverse effects that is occurred on this patient cohort. Notwithstanding these limitations, cobimetinib is effective in Rose-Hydorfman disease regardless of dosing, as we see like great responses with lower doses as well. Importantly, higher, durable, and more deeper responses were seen in patients who carried alterations in the KRAS or MEK genes. Grade 2 to 3 adverse effects were common, so providers or the practitioners should be very vigilant and closely monitor our patients for these adverse effects when treated with cobimetinib, as most of these adverse effects could be mitigated or could be resolved by early recognition and treating accordingly. I would like to thank the committee to giving us this opportunity, and this is our pre-pandemic state with the histiocytic working group. This is the post-pandemic state, or during the pandemic, we increase in numbers, and I am open for any questions.
Jitma, thank you very much. One question that I saw in the Q&A was, just to some comment on who were the patients you were treating with COBE in the first place, since they were a minority of the RDD cohort, in the larger sense.
Yeah, so thank you for that question. So there wasn't a selection criteria. So most patients, these were, so as mentioned, 7 were upfront. Cobimetinib was used, and those patients we had the mutation response assessment before the treatment, so we were able to commence cobimetinib. The other patients who had relapse refractory or disease, where they were exposed to multiple chemotherapeutic agents or steroids in the past, some patients underwent surgery and radiation.
I think it also highlights, I think, the bigger point and the challenge in RDD is that not everybody needs systemic therapy. So another thing is how did we choose those patients? There were no strict criteria to choose COBE, but pretty much who did not respond after the initial therapy or needed systemic therapy, basically.
5 patients having treatment-limiting toxicity is pretty substantial. I'm curious if you happen to have at your fingertips what those 5 toxicities were, because it's a large number and it's worth thinking about whether there's ways to mitigate those.
Indeed. So if I can you see my screen?
We can, yeah.
Yeah. So if we go to their swimmer's plot here. So for an example, so patient number 14 who had grade 2 retinopathy and underwent dose reduction. And then the grade 2 retinopathy actually improved to grade 1, but it was persistent. So we had to discontinue treatment. Patient number 9 who had grade 2 rash, which actually held the treatment. And then we started at a lower dose and then was discontinued due to progression. And so grade 2 rash, grade 2 cardiac toxicity, the ejection fraction actually went from 60% to upper 30s. And we held treatment and start the treatment cobimetinib at 20 milligrams. It was started at 60 milligrams, and patient continued to respond, and the ejection fraction improved. So those are the dose limiting toxicities that one could appreciate.
I meant more the treatment the toxicities that ended treatment, the treatment limiting, not the dose limiting.
So the treatment limiting toxicities are the grade 3 cardiac toxicity and retinopathy, and then grade 3 diarrhea, anemia, and also those are and musculoskeletal pain. Those are the treatment limiting toxicities.
It's interesting I think the cardiac toxicity and the retinopathy, those are kind of, your hands are tied, but for some of the others, something that I've tried is various kinds of interruption schemes, treating patients on and off, and that may be something that's worth thinking about, especially when patients selected like this don't have any other options.
Indeed. So for an example, thank you, Dr. Diamond, that is a phenomenal suggestion. So for an example, this patient I was closely involved, and this patient actually had significant diarrhea starting off just after the treatment, and she achieved a response, the time for best response as a stable disease that we documented. Unfortunately, she had 11 bowel movements per day, and that led to treatment discontinuation. And this is despite trying all the Imodium and everything.
Did you have any patients, I'm sorry, I'm not seeing this immediately, who progressed on treatment?
So progressed on treatment, we do. So progressive disease, which is the orange, they progressed on treatment because they didn't achieve a response. So in fact, these were refractory patients. The reason that we continued until this was because of done outside clinical trial. This was the next response assessment for these patients mostly.
But none who had a response with subsequent progression is what I'm asking.
Well, yes, who had a response with subsequent progression happened. For an example, this patient had a partial response and achieved around 1 month, and then had a progression in 5 months.
Interesting.
So the similar. So those are the things. So this patient actually had a progression after discontinuation of treatment. So there is one patient, actually 2 patients, in fact, had such kind of but this patient had a stable disease, but this patient had a response but progressed. But important to note is that we actually, grade 2 rash, held treatment started at lower dose and then progressed. So that also should be factored in decision making.
Any other comments from our panel?
Yes.
Osama, yeah.
Sorry, I was wondering about the characteristics of the patients. Were there any who had CNS disease, and how did they respond?
That's a good question, sir. So one patient had a CNS disease, which is patient number 1 in this. Actually, if you could see that this is this patient. Unfortunately, this patient had a progressive disease and then died after we had to discontinue cobimetinib because the patient progressed on it and also had some significant adverse effects. And then patient treated with cloferamin after and died eventually in hospice. So this actually, the reason for death was the progression of Rosa-Dorfman disease in the CNS. But that is the only patient who had CNS involved disease.
Thank you.
Okay, Jitma, wonderful presentation. Thank you so much.
I will now introduce Dr. Diamond to take over for the next talk.
Does everyone see that?
Yes.
Okay. These are my disclosures. So the background to this study is that, as we know, we've seen very, very nice and lasting responses in many patients with ECD and other histiocytoses to targeted treatment. How long patients need to be treated remains unknown. From Dr. Harosh's LOVE study, there was the observation that there's very frequent relapse, at least in the specific context of BRAF mutated Erdheim-Chester disease treated with vemurafenib. However, outcomes with other targeted therapies and other histiocytosis subtypes is not well known. So the objective of this study was to characterize the frequency of relapse in ECD and other histiocytosis patients who were treated with various targeted therapies. This is a mixture of patients who are observed prospectively with treatment interruption, that's in my cobimetinib trial, and some patients who were tried off treatment in the off protocol setting. And then also to look at whether there's disease or treatment factors that are related to subsequent relapse or the absence of relapse. So patients who were studied were those with ECD, LCH, Rosa-Dorfman, xanthic granuloma family disorders, or mixed histiocytosis. And these were patients who interrupted targeted therapy entirely, followed by observation alone, or there were some who were given a maintenance or a quote unquote consolidative chemotherapy, and then they were followed for clinical or radiologic relapse. The data that we collected was whether they were on BRAF, MEK, or dual therapy, how long they were treated, what their best response was at the time of interruption, and then whether they relapsed or not. If they relapsed, were they rechallenged, and what was their best response and duration of response after rechallenge? So there's 20 patients who we were able to observe what happened following treatment interruption. 13 of the 20 were male, 7 were female, 8 had ECD, and then the rest were either mixed ECD-LCH, ECD-Rosa-Dorfman, 2 with LCH, 2 with RDD, and 2 with JXG. These were the sites of disease, largely bone and neurologic, and then various others, many with skin as well. In terms of the genomic makeup of the population, 12 were BRAF V600E mutated, and the rest were various MAP kinase pathway mutations, MAP2K1, KRAS, MAP2K2, 1 RAF1 mutation, and 1 was unknown. And there was a mix of prior therapies. About half were untreated prior to targeted therapy, and the rest had various other lines of targeted treatment. Prior therapy. About half of the patients received a BRAF inhibitor, half MEK, and then a couple were dual. 13 of the 20 had obtained a complete response at the time of treatment interruption. They've been treated, some for less than a year, some for more than a year. And then the reasons for stopping, half were the deliberate decision to pursue observation. 4 stopped for toxicity, and 2 for reasons of finance or authorization lost access to the targeted therapy. 4 of the 20 received some kind of treatment following in efforts at maintenance or to eradicate disease. 2 were methotrexate, 1 cytarabine, and cladribine. So 14 of the 20 subsequently relapsed. 13 of those 14 relapsed in the same site. They're the known sites of disease. 1 was in a discontiguous site. Of those who were rechallenged, 7 recaptured a complete response, 2 a partial response. 1 had stable disease upon rechallenge, and then 3, for various reasons, did not end up having scans following their recapture. So this is the swimmer's plot that contains a lot of the data here. The midline of the plot is the time of treatment interruption. To the left is the treatment course prior to treatment interruption, and to the right is following. And the bars are color-coded by histiocytosis subtype. And then the 6 patients who did not relapse are on the top, and those who did relapse are on the bottom. And then their disease mutation is on the left, and the treatment is on the right. So you can see visually that the 6 patients who didn't relapse had all achieved a complete response, and only 1 was BRAF V600E mutated. There were various other mutations, and they were all treated with a MEK inhibitor, one with dual therapy. And then just visually, a lot of the patients relapsed are those with BRAF V600E mutations or no mutation identified. So if we look at this quantitatively, then there's sort of a trend to patients with a CR not having relapse, and then there was a statistically significant association between relapse and a BRAF V600E mutation, as well as sort of conversely an association between treatment with a MEK inhibitor and not having relapse. So that's pretty much the data. I think in some ways surprising, in some ways not. Relapse following interruption of targeted treatment is very common. I think from the standpoint of BRAF mutated ECD, we recapitulated a lot of the results of Dr. Harosh's LOVE study. However, I think it does raise questions whether there are certain selected patients, genotypes, treatments that may be optimal for giving a try at treatment interruption. Those who are BRAF wild type and treated with MEK inhibition, and for those who relapse, the responses were generally recaptured, which provides some degree of security in terms of trying patients off treatment. And it's our team, and I will be happy to take questions before we wrap up.
Thank you, Eli. That was very interesting presentation. We'll wait for questions, but in the meanwhile, I'll ask one. If you could go back to your swimmer's plot for a second, it's kind of interesting as I was, reflecting on Jitma's presentation as well. We do sort of want to think of these as treatment-based, but I almost wonder, I was looking at his swimmer's plot and yours. The people who don't have a relapse on the top are mostly KRAS and MEK mutated ones. So makes me wonder in a bigger sense, is this a function of biology? Yes, MEK inhibitors work. And I just wanted to see if you had any thoughts on that. And in your own larger cohort, is there any difference in general disease manifestations on people who have, is it like less aggressive, or in general, the function of biology comes to mind? Are the KRAS and MEK mutated distinctly are distinct entities in general?
No, I mean, I haven't done this formally in my group. I remember from Julian's neurology paper that they found BRAF more frequently mutated in patients with sort of neurologic disease, and I would say informally I find that to be the case as well. I haven't done that formally. No, I don't have any formal observations about these kind of phenotypic differences. To the eye, these patients were not, sort of in terms of their aggressiveness or organ distribution, very different from others.
Thanks. We have a question saying, looks like all of those who did not relapse had therapy for at least 15 months. Did you look at duration of remission and relapse rate?
Yes, there was really, you can see it here, that there was really no difference. And I think that's because what's not obvious is that, you know, all of these bottom patients were treated for more than a year. So there were many patients who relapsed who were treated for quite a long time. So we did look and there was no difference.
Another question is, do you have new biopsies for those who relapsed? I guess the question is the biology the same, or are you finding new mutations in those instances?
I would say maybe 2 or 3 times we biopsied, and I never found a new mutation. And I just want to make the observation, because I didn't say it during my presentation, that, you know, the chemotherapy did not make much of a difference. You know, in the 2 methotrexate patients, their relapse was quite late. They had a sustained response for, you know, as you can see here, 2 to 3 years, but did eventually relapse.
Osama has a question.
Yes, among the patients who did not relapse, sorry if I'm going back to the CNS, were those, and you had CNS disease and did not recur in the CNS after you stopped?
None of them had parenchymal disease, but some had dural disease. So no true brain parenchyma, but neurologic, yes. But it's something that I should probably look at more formally.
But they did not recur in the brain.
There's, I think, at least 2 or 3 of those who had dural disease who did not recur.
Interesting. Thank you.
Zdenka has a question.
Second. Yeah, I would like to ask if there was a better response, slower relapse rate after using a dual inhibitors.
It was, let me see. You know, I don't give a great deal of the duals in my practice, so there was only 2, you know, and they were 1 each. I mean, for what it's worth, the only BRAF patient who did not relapse had received both, but there aren't that many of my patients who are on both who I've tried stopping, perhaps, you know, because they have more severe disease, and so I'm more skittish about stopping, but I don't have much of an answer to that.
And we have question, any correlative tests on circulating tumor DNAs? Do you think assessment of this, if positive pre-treatment, could help determine who would relapse, like MRD evaluation in some other hematologic malignancies? Yeah,
that's an interesting question. So I would say for a few of the BRAF patients, you know, where the ddPCR is sort of more readily available and quantifiable as opposed to the other mutations. There were patients who, you know, their cfDNA BRAF was negative at the time of treatment interruption and then did become positive in advance of the clinical or radiologic relapse. So I don't have this systematically collected for everyone, but in those who I did have it, it sort of played out the way that you'd expect.
Among the patients who had a PR on retreatment, I guess I could get the answer if I just figure out from this plot. But are they the ones who also had a PR before? I'm just trying to see, like, is PR going to be a definite no for stopping? Just trying to pick up signals how this could influence practice.
Yeah, I mean, if you look here, PRs obtained PR, you know, re-challenged, got PRs and CRs, mainly re-obtained CRs. I didn't think about it, but just looking at the dots and stars for the most part.
Any thoughts on you know, doing chemo in some of these cases after you finish?
I mean, the oral methotrexate was really meant as a maintenance, you know. My cladribine efforts were big flops, so I'm not eager to try it again, I'll be honest.
Okay. Well, if anybody doesn't have any questions, I'll give it back to Dr. Diamond to close.
I will do a quick wrap up with many thanks to the sponsors of the HS in this event. There are ways to support the Histiocyte Society by Amazon or with your membership. Please do complete the survey about the event if you can, and save the date for the next webinar, which is hosted by the scientific committee. And with that, I will bid everyone a farewell. Thank you for attending, and have a wonderful rest of the week.